Hello friends, Indian Chess Society, in association with its educational partner Glenmark, has finished 15 webinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this webinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API EPICS webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India, with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these webinars.
Good evening, everyone. We are yet again joined for another webinar today. And as we all know, today is a very important day, the World No Tobacco Day, commemorated to understand the importance and the impact of tobacco in health and also in disease. So this year, the World Health Organization team for World No Tobacco Day is on to grow food and not tobacco, emphasizing on the need of cutting the source of tobacco right from where it is being cultivated. So here we are today. We have got an elite panel led by Dr. Saurin Gunia. Sir is from the Department of Pulmonary Medicine. He's the additional professor at AIIMS Bhubaneswar. Along with that, we have an elite group of panelists. Dr. Chitra V, Assistant Professor, Department of Pulmonary Medicine from St. John Medical College, Bangalore. Dr. Hariharan Iyer, Assistant Professor, Department of Pulmonary Medicine from All India Institute of Medical Sciences, Jodhpur. Dr. Dheeraj Khadla, Associate Physician, Department of Psychiatry, Krishna Medical College, Vellore. And Dr. Nitesh Gupta, Assistant Professor, Department of Pulmonary Medicine, VMMC and Safdarjung Hospital, New Delhi. And myself, I am the moderator for the day. I'm Dr. Avinash. I am Assistant Professor in the Department of Respiratory Medicine at Krishna Medical College, Vellore. I now formally invite our lead expert, Dr. Saurin Gunia, to start the discussion. Dr. Saurin, sir, am I audible? Are you able to hear me?
Yes, audible, please.
Yeah. So, shall we move on to the first question?
Yes, sure.
Yeah. The first topic of discussion is the role of a pulmonologist in smoking cessation on the 5-way approach. Over to you, sir.
Thank you, Dr. Avinash. As you had rightly said, this, as per the WHO, today is the World No Tobacco Day, and today is the right day to bring up this topic of tobacco cessation. And I think the role of pulmonologists in tobacco cessation is very, very important, because most of the patients with respiratory diseases, we are the first point of contact. And I think it becomes very important. We have got a very pivotal role here to first initiate the process of tobacco cessation. And for that, there is already a well-established model, the 5-way model, which is in place. But practically speaking, I feel it's very important that we include this habit of asking whether there is a history of tobacco intake or not. In any form, whether it is smoking or smokeless tobacco, whatever it might be. So I make a habit that whenever in our clinical practice in the busy OPD, I never fail to ask the first question that whether you smoke or not, and I make sure that I record it, I document it. So that becomes very important because whenever the patient comes for follow up, then I can know that yes, patient was a smoker, and I get advised to quit smoking, whether he is following that or not. So the first and most important step is to ask. We have to ask whether there is exposure to whether he's an active smoker, or if not an active smoker, whether he or she is exposed to secondhand smoke or not. That is also very important. So then, let me be very frank here. We should not just stop by merely asking. Suppose if the answer from the patient is no, we should not just stop there, because frequently what in our experience what we have seen that the patients usually do not reveal the complete history. So if the patient might have stopped, just stopped smoking for say last 2 weeks, then also he might say that I'm not smoking. So that doesn't mean that he's not a smoker. So we have to again ask whether he used to smoke previously or not. Then for how long he has stopped. Then only we will get the clear answer from the patient that yes, he is a smoker or non-smoker. So once we have known that patient is a smoker, then we have to advise. The next A is the advice. We have to advise the patient in clear and very strong way that you have to enough is enough. You have smoked for quite enough time, and you have to stop smoking in order to regain your lung function or whatever your pain you're going through for your disease process. So then once we advise the patient regarding smoking cessation, then we have to assess the patient's willingness to quit or not, whether the patient is ready to quit, and how eager he is to quit smoking at this moment. In our practical experience, what we see is that because since the patient has been suffering, either the patient is having a breathlessness or chest pain or whatever might be, then they usually are very eager to quit. They want to get rid of the suffering which they are going through. So if the patient is not ready to quit, then there is a different mechanism for that, the 5R model. But if the patient is ready to quit, then we should come forward and help him, assist him in making a quit plan. We have to make a definite personalized plan as per his environment, his surroundings, his occupation, his day-to-day living, whatever the situation might be. So we have to spend a minimum 5 to 10 minutes time in the OPD to make this plan. Preferably a quit date should be set at say around 2 weeks. Then we have to identify the obstacles that he might be facing while quitting, and so we have to assist in all possible ways to help him quit. And then once then we can ask the patient for follow-up. That is maybe after 1 week, and then after 1 month from the quit date. So that is the last A where we need the follow-up of the patient. Then we need to assess whether how the patient has been doing, whether he's really attending or not. Then it can be a physical follow-up, it can be a telephonic follow-up, whatever it might be. But we have to keep a track of the patient. And as I said in the initial words, that making a note of it in the OPD card makes it life very easy, because we can know during the follow-up that whether the patient was a smoker or not, whether he's going to quit or not. So that's in brief how we go about the 5A model to initiate the process of tobacco cessation in our patients.
Yeah, very important points, Dr. Saurin. Basically, the tip of the iceberg is visualized when we ask the patient. A very relevant point, because unless we ask about the current, past, or the far past use of tobacco, and also about the different products that are used. Some people may use both smokeless and smoking tobacco. So unless we ask and document, we cannot move on to the next steps. And whenever we ask and the patient comes forward, very, very valid point. So with that as a primer, we move on to the next topic. How do we assess the severity of nicotine dependence? Over to you, Dr. Hariharan.
Yeah. Thank you, Dr. Avinash. First, I would like to say that Dr. Soren has raised very important points about the first step, that is asking whether you smoke cigarettes. Because only when you ask and you know that your patient is smoking, only then will you come to the next point, whether he's actually dependent or not. Because the key is to break that chain of dependence, because unless patient is not willing to give up smoking or he's not able to quit, the lung damage continues. So to assess the nicotine dependence, basically you have certain scores. Like the most common one which is described and validated is the Fagerstrom's test. And second is the heaviness of smoking index, or HSI. There's also one more test, or you can say it's basically a single time after which, after getting up from the bed, the first cigarette when the patient smokes after getting up from the bed, that is time to first cigarette. That is also an important question that gives you an idea of how heavily the patient is dependent on smoking. So, for coming to the first test, that is the Fagerstrom test, it's basically a test of six. The module involves 6 questions, which involves, how soon does the patient smoke his first cigarette after waking up? Does he find it difficult to refrain from smoking in places which, it's forbidden to smoke, like a church or a temple? How many cigarettes does he smoke per day? Which is the most common, which cigarette would he most likely to hate to give up? Like whether it's the first one in the morning or the other, because that also implies the amount of craving he has. Then, does he smoke more frequently during the first hours after getting up? Or he smokes when, even when he's very ill and his general condition doesn't permit, still he continues to smoke. All these are graded in terms of, there are point system given to them, and based on the point system, you can be either not dependent or heavily dependent, and a score of more than 4 give you an idea, or it's cut off for determining the nicotine dependence. And based on this, basically you can offer therapy. If the patient is dependent on nicotine, that means he needs therapy. And the other, that is the heaviness of smoking index, basically it's a subset of the Fagerstrom's test. And it takes into consideration 2 products. It is the number of cigarettes smoked and the time for the first cigarette to be smoked after getting up. So based on this, you again have a grading of not dependent to severely dependent. So I would say these are the basic tests which are very easy to implement. You can just keep a handy paper which is printed score, and you don't need to memorize them. And once you assess, it's part of assessment. Apart from assessment for smoking, you need to assess for nicotine dependence, and then direct the patient to the, I would say, addiction center based on heavily dependent nicotine, because that would go complete assessment and treatment for smoking cessation habits.
Thank you, Dr. Hariharan. Very valid points. So once we address that there is a tobacco usage, assessing the nicotine dependence gives us the idea of how to proceed further. Are there people who require intervention? And if the intervention is required, what level is required? Very, very key points. And a very important point that you have raised is the dependence severity from the Fagerstrom questionnaire or HSI actually tells us that how fast after waking up the person takes the first cigarette. That actually reflects a very severe, the shorter the time, the higher the dependence. Isn't it? That's a very relevant point. And as you very rightly pointed out, it does not take much time. It's just a checkbox. If we have a small card along with us in our outpatient department or in our wards, the moment we come to know, we can just checkbox and put a score there, which gives us a clear idea and direction where we are going. Very valid point. So moving on, we will discuss, after looking at the dependence severity, are there any diagnostic tools that are available to assess nicotine addiction? Over to Dr. Nitesh Gupta.
Hello everyone. Am I audible?
Yes, Dr. Nitesh, you are audible.
Okay. So apart from the scoring criteria, which Hariharan sir has very rightly pointed out, we have few diagnostic tests, but they are in addition to the scoring criteria. They are not themselves a diagnostic criteria. So we have a very old device, about 30-35 years old device, breath carbon monoxide analyzer, which do 2 things, which organizes the carbon monoxide ppm particles and also tells us about the carboxy hemoglobin content. So 0 to 6 value in the carboxy hemoglobin in the ppm particle, it says it's in a normal range. However, It also depends when the patient has last taken a smoke. If patient has left smoking for last 7 days, then this may even come within a normal range. The other levels is to see the nicotine content, like in urine, we see carnitine, and in saliva also we measure carnitine. So these two measurements also help us in knowing whether patient is smoking, first thing, whether patient has quit smoking, how many days back, and if and practically they are more useful in knowing the response to the quitting of therapy. So this is where they are useful apart from diagnostic and also in follow up.
Thank you, Dr. Vitesh. May I raise one question there? So, is it mandatory to measure carbon monoxide breath or the cotton levels to assess severity, or can we let alone leave that? Or how is it? How does it go?
So they are not mandatory to classify or to start the therapy of a patient. They are basically a visual representation, a number. When you show patient a number, okay, your carbon monoxide level is 50, it is dangerous for your health. It has a positive impact on his quitting of smoking. This is where these both things are useful, and other impact is on follow-up of these patients.
Yeah, that is a very important, valid point, Dr. Nitesh, because it gives a positive contribution to the patient, telling that we can the carbon monoxide can be shown in zones, color zones, like green, yellow, and red. So if the zone comes in red, we can tell them, see, this is how critical the level is in your breath. After quitting, when they come back in 1 month or 3 month follow-up, we can show that it is falling down. Same with cotton. Definitely. And one more thing is, yes, Dr. Nitesh, please.
No, I just wanted to say that it can also be used to, to check whether the patient has actually quit his smoking or not.
Yeah.
Sometimes, so we used to do it before PFT, some patient used to smoke and we used to do that, and then, that can be used. Yes.
Yes, sir.
Can I say something?
Yes, sir. Please add. Please add.
Rightly told. Actually, we come across such patients practically who tend to conceal these things. Means they don't want to reveal the cigarette or bidi which they don't want to lose. Actually, the one in the first one in the morning, and usually the one after lunch. So these are the two times which they don't want to lose. So they might conceal these things. They might not reveal these things. So it's better that we check it's a very rapid test by a CO2 monitor, and then we can usually find out whether the patient is continuing to smoke or not. We can then address the situation.
Yeah, that's a very important perspective to the. It not only aids in our diagnosis and follow, it also tells us whether the patient is telling the truth, and we can have objective evidence of whether actually the patient is still using it. Very, very important point. Moving on to the next topic, behavioral counseling and the role of occupational therapy in smoking cessation. Over to Dr. Dheeraj.
Thank you, Dr. Avinash. Thank you all for having me. Behavioral counseling as such is a very wide kind of topic. Like, it can be done at an individual level, at a group level, or even it can be done by the individual through an online resource or through text messaging. So it's very wide. So overall, the content would be that there would be education about withdrawal. So when he quits, what would happen? What changes he would go through. He will not be able to concentrate. He'll feel a little irritable. So he should be aware of these things when he's embarking on the journey. And of course, he can be given assistance regarding NRT and the treatments that are available for reducing the withdrawal effects. The second thing is about the person's individual cues that kind of trigger his craving. And as Sir rightly pointed, the early morning one is very difficult to quit because whole night he's not been consuming. All the receptors in the brain are now empty. The nicotine is washed off, and so they're all really waiting for the nicotine to come. So that's the most difficult cigarette or tobacco use to quit. And after lunch, people feel a little drowsy, and they're after heavy lunch, though they want to feel a little active, so they want to have the afternoon one also. So for different people, it's different. Maybe in the break room or when they're relaxing after the work is done. So they may have their own specific cues. So we need to teach them what kind of ways they can either avoid the situation or change the kind of situation. For example, there's a party. They can say, "Oh, not party in this friend's house, which is a bachelor's house. You can come to our house and it's a no smoking zone, no drinking zone." So change the scenario in which substance use would be limited. And also, if not possible at all, then he should escape the situation. So all mechanisms to avoid this. So specific coping mechanisms when there is peer pressure that needs to be taught. And also in general stress management, distraction skills, like they could be behavioral, like I can do something like knitting or painting or something, or cognitive tasks like making a to-do list when I'm feeling the craving would be helpful. Exercise in general, then visualization of if I don't quit, if I quit, I'll be able to have health, I'll be able to play with my children, I'll be able to see their marriages. That kind of thought, positive visualization, the benefits of quitting, when he thinks that will reduce the power of the craving. So these things need to be taught. So, but ultimately everything begins with what Soren sir first said, to ask people about all forms of tobacco use, and to advise them. So many times we think that psychological counseling is actually, we don't give advice. In deeper levels of psychotherapy, we don't give advice. It's their choice. But here, when you're trying to address a whole group of OPD patients, we must give blanket advice to everybody. A person may respond after 10th advice. It's like you're hitting you're hammering a nail. Maybe on the 10th one it will go in nicely. So we should never stop getting tired of giving advice. Routinely asking itself would give the person some level of motivation. So one important thing is about improving motivation. I mean, in your practices, many of them would continue to smoke, though they're coming with asthma, COPD. So how do you should develop discrepancy between where they are and where they want to be? Create that discrepancy and avoid arguments. Then you should try to roll with resistance that they would offer. They were telling lies. So you found the carbon monoxide is high. We should not scold them. We should understand. Yeah, I understand. It's okay. I wouldn't have scolded you. You could have as well told me. So he knows that you are not judgmental. So he's going to come back to you. He's going to stay in therapy. And express empathy. Tell, I know it's difficult. It's one of the most addictive substances in the world. So of all substances, I don't know if you all know that it is the most addictive substance. If I smoke once, first time if I smoke, there 100 people do it, 32% will become dependent in their lifetime. For cannabis, it's only 9%. For alcohol, 15%. For heroin, 24%. For tobacco, 32%. Highest for all substances. It's the most addictive substance. When we know it, we become a little more empathic to people. We should also express that we believe that they can do it with help. They can overcome. So that supporting their self-efficacy, that they have it in them to overcome, that would, I think those are the aspects of motivation. And then there are aspects of relapse prevention. When after he quits, again he's going to get into these high-risk situations. So how would he cope with these would be something that we need to discuss. And there's a lapse and relapse. Starting cigarette is not a problem as much as smoking in the way that he used to smoke in the past. So if he started once, it's better that he reviews early so that we will actually get back to these steps, so that he doesn't end up with a complete full-blown relapse or a bigger complication with the lung. So I think that kind of gives an overview of psychological treatments. Yeah, you asked also about occupational therapies. I think most places don't have full-fledged workers in mental health. So occupational therapists actually double up as people who can do like multi-purpose workers. Like they have good understanding of mental health. If they're given specific trainings regarding nicotine dependence, they will be able to do this motivation enhancement and relapse prevention very well. And also they have a very good way of integrating substance use into their daily life. Like they are the ones who assess activities of daily living, instrumental activities. So how does this substance affect work? So what aspects of work are increasing the chance for use. How in the daily morning activity, like he's not able to defecate properly without this tobacco. So these kind of things they are able to integrate well. So they relate with the patient in a very nice way and help them if they are also using they're part of the treatment team.
Thank you, Dr. Dheeraj. Very core points being how to be open, non-judgmental, non-argumentative, and understanding that relapse is part of the process. Nicotine is very addictive. It gives us a wholesome idea of what the patient is actually going through. So we should be empathetic to the patient. At the same time, we should give a strong, personalized message and give them the option. And at the same time, we should be telling, like it is very similar to how we manage diabetes and hypertension. We do not tell the patient, yes, your sugar is 300, you have an option of taking insulin or OHA. We tell them that, see, this is the option, you have a problem, we have a solution. So I think the positive, proactive approach being non-judgmental, that is the line clinicians have to draw, and having a multidisciplinary team like a psychiatrist, psychologist, and occupational therapist will actually improve the outcomes. May I ask one question? So, how frequently do you think a behavioral therapy session should be started for a patient? Like, how many minimum? I know there is no ballpark figure, but if you can just tell us from your experience, because I personally know Dinesh has been dealing with the addiction. Our team has been integrating with him for so long, so that is why I'm asking the question.
I think early on we should offer more. Maybe weekly once to begin with, or weekly twice if they're local people, they can come to increase their motivation and help. So it's but once they are in the flow, then you can slowly phase down the visits. So if they've already quit, maybe keep them in follow-up at least once in 3 months. I mean, they're even outstation people, they can come once in 3 months. Just don't let them go off for too long, because if there's a relapse, then we have to restart everything again. So keeping things really tight and close early on is very useful. And there is evidence that the more time you spend, and the more number of sessions you have, the more time you give during a session, they are all associated with increase in abstinence rates. So it could be even simple counseling. More the time, more. So even if high tech type of intervention like cognitive behavioral therapy, after a particular point, like after 26 weeks of cognitive behavioral therapy, there are no further gains. But till the 26 weeks, even simple ones could lead to greater gains. So I think it's important to give time. It's not the time of a chest physician. It's very precious. You will have to see a lot more people. But I think that should be given to other staffs who will be able to train, like diabetes educator is there. I'm sure respiratory technologists are the ones who are there to educate on how to take the puff and all those. You have other allied health workers. I think some part can be given to them for doing this kind of work.
Yes, Dr. Dheeraj, I think that's a very valid point. Getting our team equipped to deal with, so that even in a busy clinical practice, we'll be able to integrate anti-tobacco practices. Thank you so much. We move on to the next topic, nicotine replacement, other pharmacotherapies. Over to Dr. Chitra.
Thank you, Dr. Avinash. When it comes to pharmacotherapy and smoking cessation, it has to be a combination of evidence-based treatment and an individualized approach. We have the nicotine replacement therapy like an asthma medication. We have a controller and relievers. Controller as a nicotine transdermal patch, and the relievers are gums, lozenges, and sprays and inhalers. Coming to gums, the first question you asked, like Dr. Pointed out, that when is your first puff? If it's within the first 30 minutes of waking up, you start with a dose of 4 milligram of nicotine chewing gum. Ask the patient to, you use a method called chew and park. You ask the patient to start chewing till you get the tingling sensation, and then keep it, park it till it goes away. Again, do that cycle for 30 minutes. You can use one chewing gum for, not use more than an hour. And again, like I said, the number of cigarettes per day can be equated with the number of gums that the patient can use. The adverse effects that is associated with chewing gum are irritation inside the mouth, and patients can have jaw pain. And in patients with TMJ disorders, it's difficult to use. And like I said, it has to be individualized. There's no point giving a chewing gum to a patient, an elderly patient who's using a denture. That will be a bad choice of NRT. The other option, transdermal patch. Again, the question would be how many cigarettes do you smoke in a day? If it's more than 24, then you start with a dose of 21 milligram of transdermal patch, and over a period of 6 weeks, you taper it down from 21 milligram to 14 to 7 milligram. And if it's less, then you start with a dose of 14 milligram. The consideration would be that it has to be rotated every day, and skin irritation is an expected side effect. Lozenges, the dosing is same as that of gums. The advantage is that it can be used in patients who have dentures. That is about the nicotine replacement therapy. Yes, we have the sprays and the inhalers. Inhalers are almost like cigarettes, so that is an advantage. It all helps in dealing with the craving symptoms as well as the withdrawal symptoms. When it comes to drugs, we have two drugs, varenicline and bupropion. Varenicline with a nicotine replacement therapy, transdermal patch is studied. So that is the preferred treatment for pharmacotherapy in smoking cessation. The dose would be 0.5 mg to start with, and it can be titrated to 1 milligram. The mechanism of action is alpha 4 beta 2 agonist, and it again helps in craving symptoms as well as withdrawal symptoms. The expected side effect is nausea, and there are no major concerns. Initially, there was a box label warning to be used in caution, with caution in patients with psychiatric disorders, but after the EAGLE study, that has been taken off. The other drug is bupropion. The precise mechanism of action is not known, but it helps by reducing the withdrawal symptoms as well as the craving symptoms. One, it helps in that following cessation, they tend to gain weight. That is one thing that is taken care by bupropion. The post-cessation weight gain is not seen much with bupropion. The dose would be to start with 150 milligram only, which can be increased to 300 milligram over a period of 3 days. And the caution would be to use in patients with seizures, it's contraindicated, and also in patients with psychiatric disorders like bulimia, anorexia, one should use bupropion with caution. The duration of therapy would be 12 weeks, but in certain conditions, it can be extended even after 12 weeks. Overall, so varenicline and nicotine replacement therapy is the recommended choice. So when it is compared to an isolated NRT and an isolated varenicline therapy, it has to be used in combination. But like I said, individualized treatment, varenicline is expensive. Chewing gums are less expensive. Whereas lozenges, transdermal patches are expensive. So you should look at the patient before prescribing. But yes, varenicline and NRT is the recommended treatment.
Thank you, Dr. Chitra. Very complex. It's an elaborate question, but you have made every point very clear. A couple of questions and a couple of comments. One, you have mentioned very clearly that a combination therapy is superior to monotherapy. And there are specific indications and methods in which nicotine replacement is used, especially gums, because people are used to using chewing gums. When they chew and they find the taste is gone, they spit it out. That is not the way chew and park works. That tingling or the peppery taste has to come, then you have to park it till that sensation goes off and then rechew again. So that teaching patients that technique is very important. If it's pads, very good, but the only problem is it takes some time for the level to come. So you may need to cover up that level, sustain with some short-term gums or other methods.
That is only a controller. You should use a reliever if required when you're using a patch.
Correct. Like what we use in asthma and COPD. A very good analogy. That's really good. And when it comes to pharmacotherapy, there are specific indications and some contraindications like seizure disorder, renal disorder. And earlier, the black box warning was there for varenicline because of neuropsychiatric, which, as you rightly pointed out, the EAGLE study had taken it over. So that gives us a clear point. May I ask one question? So if we are to prescribe one thing for a patient, what would that be? Will you start from NRT or will you start from pharmacotherapy? If you have a personal choice, how do you decide?
So first of all, like I said, individualized treatment, varenicline and NRT is the recommended choice. When it is NRT alone, if the patient can afford a patch with a gum, is that I would recommend. Or else, if there are no contraindications, start with bupropion and an NRT. I mean, individualized. You look at the patient, you look at his pocket, and then decide.
Okay, that's great. That's great. So that's a good discussion. So we'll move on to the next topic. Over to Dr. Hariharan, a very interesting and rather controversial point. E-cigarettes, a friend or foe? Is it a new menace or an alien cessation?
So, as you told, it's really a controversial thing to be talking about. So, first, what I would do is just give a brief about e-cigarettes for the audience, just to set the context. So, it's basically an electronic device which has three parts: an atomizer, a cartridge which has a liquid, and it contains nicotine along with some flavoring agents, and you have a battery. So, what the principle of e-cigarette, which is different from conventional smoking, is that when the patient presses a button or as per the working of the device, there is an aerosol generation from the liquid which is there by heating, and that is what is inhaled by the patient, and the nicotine reaches inside. Lately, there have been non-nicotine based e-cigarette devices as well. Now, coming to friend or foe or menace or aid in smoking cessation. So now, if you look at the data, there have been studies like the study of 2019 published in NEJM with regards to e-cigarette versus the conventional nicotine replacement therapies, which Dr. Chitra rightly was discussing. There have been a trend or evidence pointing towards better abstinence rate at the end of 1 year with e-cigarette use. In fact, if you look at the Cochrane review, which was published in 2022 November, if I am not mistaken, which included 78 studies, and even in that, the authors do conclude that there is a benefit, so there is a moderate certainty of benefit of better abstinence rate with e-cigarette use. However, now I would like to come to the second part, which is the negative effects. With regards to data, number one, the Cochrane review which I was talking about, there are almost 50 studies out of the 78 where there is a high risk of bias amongst the studies, number one. Number two is that there is no long-term data. Especially the authors also mentioned in their analysis that we don't know what is the smoking abstinence rate after 2 years. We don't know. There is evidence is lacking as regards to the long-term data and the safety rates. We all know that there have been concerns with regards to e-cigarette use in terms of vaping associated lung injury, acute lung injury, that is the E-Valley, which was described and by the CDC, where there have been even cases of ALI and ARDS and up to deaths also have been reported due to the use of e-cigarettes. And it has been found that the vitamin E acetate, which is a flavoring agent used in these e-cigarettes, has been the culprit for causing ALI. There have been reports of acute eosinophilic pneumonia as well. So there are concerns regarding the use of e-cigarettes. So rightly, our government of India has banned the sale of e-cigarettes from 2019. Second, there have been also, if you look at the psychological point of view, if we promote the use of e-cigarettes, it would be like a norm, that it's an accepted norm that you can use e-cigarettes, especially in the young and adolescent age group. It will be like it's okay to smoke an e-cigarette. And there have been studies which have found that consistent use of e-cigarettes by the flavor of nicotine which they get, there are more chances that these people can convert to actual form of smoking once they start using e-cigarettes, especially in the children and the adolescent age group. So that can be a wrong thing or a wrong message that, if you promote e-cigarette use as a nicotine dependence therapy, then they can actually go back to conventional smoking, which is, harmful. So overall, if I want to summarize, there is some data towards a betterment in terms of abstinence rate control at the end of 1 year, but still, in the absence of long-term efficacy and safety data, safety concerns, I would say, it's my personal opinion, that at present it should not be marketed very aggressively for as a modality of smoking cessation over conventional, proven therapies like Dr. Chitra was rightly discussed of, gums and transdermal patches and varenicline. So my take on this subject is that it's better not to use it till long-term efficacy data and safety data are available.
Thank you, Dr. Harian, for giving a very comprehensive overview of a very controversial topic, as we initially mentioned. So, the first the big $1 million question to you is, if you have a patient who comes to you who's asking advice on using e-cigarette as a cessation tool, will your answer be yes or no as of today?
So I would assess the educational status. So if suppose the patient is asking about e-cigarette, I assume that he must be an educated person. So what I would like to tell him is the facts which are on paper, black and white. That A, there is some benefit, but B, long-term safety and efficacy data is still not known. So I would give him an answer of overall no. I mean, the others could differ, but that is what is my take.
Yeah,
especially
thank you for
the government is banned it. So, so we should be in tune with what the government
says. I totally agree with you, and I think that's a very proactive step the government had taken, because if you take the West, all these data are being generated across age groups in the UK, Europe, and US. The young and adolescent people, the Cochrane review, which you rightly mentioned, has shown that there are a lot of children, school-going, college-going teenagers who are using vaping. You can see pictures on social media in the bus stops, and it's readily available everywhere. For the refill station for the vaping cartridges are available in the West, which is not seen in India, luckily, because of that ban. And I think that is rightly put in place till the long-term data arises. And secondly, the vaping associated lung injury is a big problem. In fact, NEJM has put forward a separate page for all the vaping related lung injury papers, which is published in NEJM altogether. And even today, as we speak, the FDA and the WHO have not approved e-cigarette as a value method, even though the Cochrane review has come recently, which is in logheads 2. So that's a very comprehensive overview. Thank you, Dr. Harian.
You are not audible, Dr. Avinash.
Oh, I'm sorry. The dual addiction for patients who are having nicotine and alcohol or nicotine with other substances. Over to Dr. Dheeraj for the discussion.
Yeah, if I may, before I say anything, maybe if I can add one line about e-cigarettes.
Absolutely, yes.
Many addiction psychiatrists actually believe in harm reduction. Like, there is harm associated with the substance use. Is there any way that harm can be reduced for this guy, even if he continues substance use? So in that manner, there will be a group of addiction psychiatrists who would say e-cigarettes would reduce the number of carcinogenic chemicals that are being taken in by this guy. So, but if you see addiction as such, nicotine is also independently addictive. And why is it that people are not addicted to nicotine gum and all? Is that the kick is not there. The increase in the blood, the nicotine level is not as beautiful as in the cigarette, which gives a nice peak, and as ma'am said, inhaler comes close. But vapes will give a good high, and the juice can have high concentration, so it can deliver more nicotine as well. So people who are using e-cigarettes could be heavily dependent on nicotine, even if they are not getting. So from addiction perspective itself, if a person starts with e-cigarettes, he is going to be nicotine dependent. So recently I went to Missouri and took some classes for young school students. And I came to know in Missouri schools, 70% of kids are using e-cigarettes. And that shook my head. We have to be very careful about our messaging. So as Sir rightly said, we took a very conservative stance. the government is taking a conservative stance. Maybe for a severe cigarette user who's not able to come out, he may try in his own style. But we are not. We would be very careful recommending, and definitely not uh, um, promote it as a promotion is absolutely no for any of these products. But even as therapy, I think we have to be very careful. So, having said that, you asked about dual diagnosis. So, in addiction psychiatry, the meaning of dual diagnosis is having a mental illness along with a substance use disorder. That's the dual diagnosis. Like schizophrenia with nicotine dependence or panic disorder with alcohol dependence. But you meant so even in that diagnosis, there's one small caveat. They exclude nicotine dependence because it's so common. So, nicotine dependence is not considered a dual diagnosis. It's assumed a lot of people will have nicotine dependence. So, it's from this you should get the idea that nicotine dependence is given very low priority in practice in psychiatry, in practice of general psychiatry. But so is the case when a person is using heroin and is also using cigarettes, is or BDs. This will assume a much lower priority than addressing the bigger substances like alcohol or opioids, which have more severe withdrawals, more severe harms in the immediate in the immediate future. So therefore, uh, if I insist on abstinence early in the treatment, he will go totally out of treatment. So I should rather allow him to continue in the initial phase. But uh, so a lot of psychiatrists don't bother about nicotine dependence when they're dealing with more severe mental illnesses. However, I made it a point to start asking, having spoken about nicotine in different lectures, I became very conscious that I should offer, I should ask, I should assess readiness to quit. So I have been asking patients, and surprisingly, many people are actually willing to quit. So in many of my inpatients now with mental illness who are having nicotine dependence also, they are setting quit dates. They are reducing the number of cigarettes during their IP stay, and the cigarettes are being given by the nurse. But we are able to see that we are able to calm down. I also offer them NRT whenever they need it. So if they were to set up a quit day, so it is all. So is the case with all the people with alcohol dependence. So offering help and asking and knowing their motivation and working will be very important. However, priority wise, nicotine withdrawal should not be the reason why a person should quit the therapy, the larger issue that he is facing. So that's something that we need to have in mind.
Okay, Dr. Dheeraj, we understood that when we have multiple challenges, we need to identify the larger challenge. At the same time, not lose focus in the individual components. So we should keep it at the back of the mind, maybe drive it forward, and when the patient is ready, maybe give the option. But asking still remains a cornerstone, because that will give us an idea whether there is more than one addiction the patient is, or more than one diagnosis the patient has. Thank you so much. One second, I'm sorry. My screen got just shut. To Dr. Nidesh Gupta, how to approach a case of difficult quitting and a relapse in quitting?
So difficult quitting, just like as we have compared this thing, difficult quitting is patient whom you have tried multiple modalities and still he is not able to quit. And relapse is when patient has quit once, but he again goes back to smoking. In both the case, the primarily we again go back to behavioral component as a primary modality for treatment, because pharmacotherapy works to an extent, but behavioral component plays a larger role. Whether we again need to identify the trigger, what has again triggered his started smoking, and we need to identify whether pharmacotherapy was working or not. So whether the patient was taking the drugs appropriately at the right time or not, whether or and whether he has continued for the similar duration as he was prescribed or not. So we again reevaluate the case, just like we evaluate in the case of severe asthma before labeling another severe asthma. We again go back to the drawing board and look at the causes, what contributing causes, what could have caused this patient of not responding to inhaled therapy. So it goes back to the diagnosis, then further comorbidities, and then we again come back. Okay, now it is not working. So this may be the scenario. So same thing in smoking cessation. We go back to the behavioral component once again, and again look at the factors which is causing patient to smoke.
It's a very valid point. So when a patient comes back with a relapse or is not able to quit as we have planned earlier, like what we have discussed earlier, also being non-judgmental, finding out what the cause is and addressing the cause rather than putting the blame on the patient or putting him in a position where he's not able to contemplate what he's required to do is a very valid point. So that gives us an overview of how to manage a difficult quitting. Now, over to Dr. Chitra on special situations in smoking cessation on cancer, cardiovascular disease, and psychiatric illness.
So when it comes to psychiatric disorders, most of them with neuropsychiatric disorders, they tend to smoke. And of course, I would take a psychiatrist opinion, and it will be a treatment in consultation with a psychiatrist for patients with psychiatric illnesses for smoking cessation. Drug considerations, like I said, bupropion is contraindicated in seizures and disorders like bulimia and anorexia. Depression and smoking cessation, vicious cycle. Once you treat a patient for smoking cessation, in depressed patient, their depression tends to worsen. So that is one consideration that we should have in patients with depression. Another problem is relapse. The risk of relapse is known to be higher in patients with substance use disorder. These are the major consideration in patients with psychiatric disorder. And the other thing that I would like to emphasize is the drug interactions. Patients who are on psychiatric medications and no major drug interactions are known, but it's, like I said, it's always important to consult the psychiatrist before prescribing your medicine. When it comes to cardiovascular diseases, when the patient is in a hospital or when the patient is with a cardiovascular disease, you can press upon the fact that, yes, it's time to quit. No more smoking. You should in MI, you should always tell that the risk of a reinfarct comes down by 30% if you quit right now. When it comes to drug therapy, nicotine replacement therapy should be used in caution in patients with MI within less than 2 weeks or in patients with serious arrhythmias. Always be aware of all this. When it comes to cancer care settings, again, right time to advise smoking cessation. Oncologists should make sure that they should be advised, ask 5 A's of smoking cessation should be pressed upon when the patient is in the oncologist clinic. When they're preparing the patient for cancer surgery, we should always emphasize that 4 weeks prior to surgery, post-op outcomes are better. Also, drug therapy, there is not much difference. Again, like I said, paracetamol and nicotine replacement therapy across all groups, safe. And yeah, this would be the in patients with cardiovascular conditions, a progressive therapy in hospital. You need not advise. Yes, you start on paracetamol and NRT right now. A progressive strategy can be advised. That would be about cancer, cardiovascular diseases again.
Thank you, Dr. Chitra. So that brings us to a very important point wherein patient might be admitted or getting treatment for some other problem, wherein tobacco addiction or nicotine addiction might be a problem which is significantly contributing to the illness, which might be unmasked only when we ask for and address the problem. And secondly, very importantly, you point out, I think I will take a comment from Dr. Dheeraj also at the end for the want of time for a minute on psychiatric illness with nicotine dependence. He has already mentioned it. So the importance of looking at multiple issues when the patient comes to us. It is very important in patients with cancer therapy. I think most of us would have, I have personally faced patients who are asking, see, already I have got lung cancer. You are telling me smoking is the problem. Now what else is there? So how do you address, Dr. Chitra, how do you address that question?
So that's what the evidence has shown that it will prevent the subsequent primary. You already have a lung cancer. If you want another cancer, So that is one thing that you should be asking. Like Dr. Dheeraj rightly pointed out in a very soft way.
Yeah, that is really, really true. And secondly, there are enough and more evidences saying that the post-op complications in resectable lung cancers or malignancies who quit smoking are better. Their post-chemotherapy response is much better. So there are good studies which are showing that nicotine abstinence or tobacco abstinence at any point will actually improve the outcomes irrespective of the current stage of the disease, even in malignancy.
Can I add one thing?
Yes, Dr. Harian, please
I
add.
would just want to say that smoking is an enzyme inducer in itself. So, if the patient continues to smoke, it might even alter the level of the drugs which you are giving. So smoking itself is an enzyme inducer. So we have to be careful so that it in itself, emphasizes that we should not allow the patient to smoke continuously.
Yes. That's a very valid point because there will be multiple interactions, multiple drugs which might be induced by smoking, which we may not be able to know. Yes, a very interesting topic, but for the want of time, I had to move on to the next and mostly the last one, last topic of the day: how to follow up a successful quit. Over Dr. Dheeraj. So a patient has quit, he has come to you on follow-up, you are happy, the patient is happy. Very, very rare instance in practice, but still some patients do come with quit. So what do you say? Okay, bye-bye, you're done with it, go back home, or how do we proceed? Dr. Dheeraj, are you still there? Or?
Yeah, I'm there. Can you hear me?
Okay. Yes.
Before I go to that, I would like to ask, talk about this dying patients. So they say, sir, I have 6 months to live. What more do I gain by adding a day or two? So I tell them. Talking with dying patients actually very illuminating to us. How they look at their life. Actually, bringing a closure actually would be one of the good psychiatric endpoints when you do therapy for people who are dying. So even when you go for a consult, it takes a lot of time to just go away and leaves you a little heavy. So I asked them, how would you like to be remembered? Like a guy who smoked and died, or you want your grandchildren to remember you as a person who smoked, who got cancer, but who fought it and quit before he died. And actually, that moves a lot of people to want to quit. So I have actually put people on NRT when they already had advanced stages of cancer. So it is possible to make a difference. I mean, at least they don't die as a loser. They die with something like I have gained something. So I think it's not how you death is all of us would die, but how we die actually is very important. So I think we can work. See the way in a different see death in a different way and life in a different way. I think that would be helpful. As thus I rightly brought, I think it's an inducer of 1A3 cytochrome 1A3. Actually, clozapine is a drug which is a costly drug, very effective drug, which will get the levels will come down when person smokes. So it's something that it will jack up their monthly bills if they smoke. If they quit, they will be able to manage with a lower dose. So definitely we should make attempts at once a patient is psychiatrically stable, we should definitely start working on substance issues, especially smoking. We will definitely focus on alcohol and all because they are more dangerous in the withdrawal stage. He may have come with suicidal attempt, but if he's in withdrawal, we'll address that alcohol issue, but we will not address the smoking issue. So we need to once they're psychiatrically stable. So as coming to how we should follow up, I think the ones whom you are in touch with are the ones with some kind of lung issue, either asthma or if they are more advanced, they may have COPD. So they have some other issue that they are bringing. So you will anyway keep in touch with them by following them up. The right lesson is when we ask and when they say that they are still abstinent, we should congratulate them. We should show excitement. Wow! So that give them meaning that when I they ask me and I quit and they're still so happy. And even when they reduce their number of cigarettes, we should show some excitement. We should be happy that they have been able to do. I think those little by little, those things that we do are the one things that make the person more accept themselves and walk towards recovery. So it's not about abstinence. Not abstinence is not the only way we should see outcome. Overall gain in health, even if they reduce the number of cigarettes, probably they would have some gains. So I would see things in that way. Of course, we want complete abstinence. That's something we all want. But I think in life we should see things in more dimensional format, not in very black and white, abstinent, non-abstinent way. So how do we follow up? I think keep and follow up for your primary condition, and if those things are also in control, as I said, 3 months, 6 months, please keep and follow up. Don't ever say, "Aap sahi ho gaye hai, bye bye." I don't think we should. We all deal with chronic diseases like and respiratory medicine, diabetes, endocrine. All of us, we should. I mean, maybe tuberculosis is something that you will dispose in. Sahi ho gaya, but I'm sure you have a follow-up plan for that also. Maybe I end with that.
Thank you, Dr. Dheeraj. That's a valid point. Looking at it from a encouraging perspective and looking at it as a multidimensional problem, and also encouraging patients and congratulating them when they actually come with abstinence. That's a very valid point. And secondly, tagging them along with the primary diagnosis. So whenever we call them for the asthma or COPD follow-up or ischemic heart disease follow-up or for the diabetes follow-up, we should make sure that we note on the side that the patient is quit for how many years now, completely abstinent, and have a good rapport with the patient so that he understands that continuing to quit is an important thing and a successful quit is a team effort. Actually, we are quite right on time. I'd like to ask our lead expert, Dr. Saurin Dunia sir, to give us an overview. Do we, sir, any points more to add or any points to
Yes,
discuss?
Dr. Hariharan, Dr. Avinash, I think we have got a very excellent discussion. All the speakers were bang on the topic and they have given a very comprehensive overview of the individual topics. And one thing I would like to add means frequently I have come across patients, means chronic patients of COPD, asthma who continue to smoke. So at times they say that when we prescribe the inhalers, so they might not comply with that. They do not have the money to buy the inhalers, but they continue to smoke. So that is where we should catch them. Means we can tell them that is how they move. I just showed them the calculation, how much money you spend on smoking. Means the amount you spend on every day, every week, every month, and then you calculate the number of years you have been smoking. So the patients are really moved by that. They say that, doctor, I have never calculated this way. I have never seen in this way. So then that moves many patients, and finally they stop smoking. And I have seen patients who come after 2-3 years, even after follow-up. They say that, doctor, that the day when you had advised to stop smoking, so since then I have never smoked. So that gives a very good feeling actually. And I also congratulate the patient for continuing not to smoke. And so this is the primary question remains that we should always ask on every visit. That is how, carrying forward the last question which you asked, how to follow up is, and the only thing I think is to ask and ask and ask. So then only we'll come to know whether the patient is really continuing not to smoke or has again relapsed. So that's it, I think, from my side. I think we had a wonderful discussion. Over to you, Mr. Dr. Dr. Avinash.
Thank you, sir. I think that's a very valid point that you put forward. Calculating the burden of addiction and translating that to care. We can actually balance the way the patient looks at the problem and the financial burden of treatment. The patient might see, okay, I've smoked this many years with this much of cigarettes. The amount of money I spent compared to that, what therapy doctor is offering is not as costly and it's going to do me good. That's a very practical point, and to continue to ask, to keep on following up. We have one question from the audience open to the panel. That tobacco cessation is always a problem. Apart from smoking, gutka is a common tobacco used among young. even educated young people. Please suggest how it can be prevented effectively. Should government pass a law to stop manufacturing? It's an open question. Anybody can take the question to answer. There's no volunteer. We met with somebody.
If I may take it, Dr. Vilas.
Yes, Dr. Harin, please.
I would just like to give my viewpoint. So, for me, I think so. The most important step is political will and administrative action. That is what is the number one step, which I feel personally should be the goal. Because just if the sale is available freely, you will never be able to control it. Like it has to be black and white. Because just by you might say that it gives you good revenue or whatever. But even it is impacting your healthcare. Healthcare burden is also rising. So the same person, if he comes with cancer, you have to provide him treatment. So there is a burden on the healthcare system as well. So it sort of balances out. At one place you're earning from the taxes, but on the other hand you're losing by providing them treatments. I think so. Political will and administrative control is the only major way out. It has to be one of the major ways out.
Thank you, Dr. Harriet. That's a very valid point because unless we curb it at the base, which reflects this year's theme of stop producing tobacco and starting to cultivate more of food, which harps on the point that unless we catch it at the base, we're not going to address the whole problem. That is a very, very relevant point. Apart from that, if we take smokeless and smoking tobacco, Gutka is like a smokeless tobacco. So, what would be our approach? Like, for example, a smoker, we have all these armamentarium of pharmacotherapy and NRT. Do we use the same method to use, or do we prefer some agent over the other? I think that's one sub question of the person who asked that question.
Can I take that?
Yes, of course.
Evidence-wise, I think it's so similar, except that nicotine gums have not shown much evidence in smokeless tobacco. Nicotine lozenges are preferred. So I think that's the one big difference between the two.
Okay, Dr. Dinesh. So do we prescribe lozenges for people who use smokeless tobacco?
I mean, we don't have supply here, so I use gums, but actually they're having poor evidence. Evidence-wise, there's a systematic review, I think, from NCPCR, the team from NCPCR Delhi. They are the ones who did Susan Nathan et al. So they show that lozenges have more evidence than gums.
Okay. What about pharmacotherapy? Do we use bupropion or varenicline in them, or we don't?
We can use. Yeah, we can.
We can use. In principle, we can.
What bupropion increases dopamine levels in the brain, so that's why sometimes it can cause. Even cigarette would increase the dopamine levels. Any kind of kick gives the dopamine. So it is assumed that it is balancing that. We really don't know how it works, but it is helpful in that manner.
Okay, thank you so much, Dr. Dheeraj. Yes. So with that, we come to an end. I don't think there are no further questions. If there are any more questions in the chat box, we can answer. Or are there any more questions, Mayur? Any more questions?
No, there are no more questions.
No more questions. Okay. And I would like to thank our expert, Dr. Saurin, and all the panelists, Dr. Hariharan, Dr. Nitesh, Dr. Chitra, Dr. Dheeraj, for such a wonderful and very comprehensive and very, very to the point discussion that we have had on the various topics. It itself is a huge topic. Each session can be part of one. Like we can take behavioral counseling in one, pharmacotherapy in one. We have concise and put it together in one. It would not have been possible without all of you. I'd like to thank all of you from the bottom of my heart. And I'd like to also thank Glenn Mark, our knowledge partner, for organizing this, and the Indian Chess Society and the organizing team for giving us all this opportunity. Any comments from any of the panelists or from our lead expert is welcome. With that, we close.